So today we're going to start talking about intermittent claudication, which is one of the issues that we deal with patients with peripheral vascular disease. So peripheral vascular disease refers to blockages in blood flow in the arteries. Remember, the arteries are what brings blood flow out of your heart to the rest of your body. So that's the plumbing that brings oxygenated blood that the body needs from the heart to the rest of the body. When we talk about peripheral vascular disease, typically we're dealing with lower extremity blockages or circulation issues, although it can be at other sites in the body, and we'll get more into the other sites. But for this particular video, we're going to talk about lower extremity arterial insufficiency. So that's blockages in the blood flow down to the legs. So the anatomy is that the aorta, which is the main blood vessel that comes out of the heart that supplies the body, comes out of the heart, supplies the head and neck area and the upper extremities, and then dips down slightly to the left of the spine underneath the diaphragm, gives off the blood supply to your intestines and your kidneys, and then about the level of your belly button splits into two to supply your legs. We won't get into the anatomy in and of itself because I don't think that's important, but we should talk about peripheral vascular disease, what causes it, what the symptoms can be, and the treatment options. So generally speaking, when I see somebody with peripheral vascular disease of the lower extremities, I tell them that there's 6 main risk factors for it. There's probably a little bit more, but the most important ones are age. So the older you are, the higher the risk. Cigarette smoking certainly does increase your risk for peripheral vascular disease. High blood pressure, high blood sugar or diabetes, cholesterol, and family history circulation problems. So of those 6, family history and age you're stuck with. You can't do anything about that. But the other ones you can. The blood pressure, cholesterol, blood sugar control, and smoking cessation, very important. So peripheral vascular disease of the lower extremities, how does that present? Well, it can be asymptomatic, meaning that the patient has blockages of the lower extremities, but either due to lack of activity or what we call collateral flow alternative channels that are developed over time, they really don't have any symptoms of peripheral vascular disease. So asymptomatic is one category, and those, I will tell you, those people who are asymptomatic do not need intervention at all. In fact, if you intervene on an asymptomatic patient with peripheral vascular disease, the risk for lower extremity amputation is higher. And so I've seen patients who've been referred to me who've been screened for peripheral vascular disease, and this is my concern with screening stuff, get screened for peripheral vascular disease, and then they get sent to me and I'm asked, tell me that these people have peripheral vascular disease. I could spend a whole another hour talking about this, but I will summarize it briefly. Screening is done by certain insurance companies and Medicare Advantage plans particularly, and they're looking for plaque buildup. They are looking for plaque buildup so that they can say, well, this patient has peripheral vascular disease. They need more aggressive management of their cholesterol or other issues. But shouldn't that be just the norm, the standard of care? So my concern is they're screening for peripheral vascular disease so they can upcode the level that they can charge Medicare for that patient. For example, if they get $1,000 a month for Medicare for a diagnosis of, hypertension in a 65-year-old man, if they can add on the diagnosis of peripheral vascular disease, then they get $1,100, and that's an annuity for the rest of the life of that patient from Medicare. So that to me is a problem, especially if the patient is not having symptoms, but more so in that people who have peripheral vascular disease, when they hear that diagnosis, it scares them. So I've had plenty of people come in who have had these non-invasive testings done at their podiatrist or family practice office or internal medicine office, and given a diagnosis of peripheral vascular disease, and they come and think, oh my gosh, I'm going to lose my legs. So first of all, it's highly unlikely, especially if you're not smoking. Second of all, asymptomatic peripheral vascular disease does not need intervention at all, and it's just risk factor modification, obviously. And the third thing is that people will have interventions done for asymptomatic or minimally symptomatic peripheral vascular disease, and that's a bloody disaster. That should never happen. But I can tell you, it happens. And that's really bothersome to me and a lot of people. So these screenings that are done, taken with a grain of salt. The tests that are done, the flow check and the QuantiFlow check, in my opinion, they're completely inaccurate. They have, again, this is my opinion, they have no role in screening for peripheral vascular disease. If I see a patient with one of these tests that's referred to me for peripheral vascular disease, I'm often asked to, because these are non-invasive tests, in fact, they're ridiculous tests. These tests, the QuantiFlow and the flow check, it's essentially an oximeter, something that measures your oxygen tension in your finger and in your toes, and then they have this algorithm for calculating what's called an ankle brachial index, which is a measure of how much blood flow is getting down to your legs. The ankle brachial index should be 1 or greater, and these tests are completely false most of the time. So I'll get referred these patients with a diagnosis of peripheral vascular disease, and I'll be asked to do an arterial duplex on them. And the reason is the arterial duplex is will show plaque. So the ABI is the ankle brachial index. It's a physiological test. It tells me what the ankle pressures are. A true ankle brachial index, which is done with blood pressure cuffs, not oximetry testing alone. Blood pressure cuffs at different levels of the leg. That's a true ankle brachial index. Maybe I'll talk about that some other time. A duplex scan is jelly. We look at it with ultrasound. And so the duplex is an anatomical test. It'll show you where plaque is, if there's plaque. And so, am I surprised that people have plaque in their lower extremity arterial circulation? Not at all. I mean, if you're 8 years old, hell, I'm 62 years old, I probably have some plaque buildup somewhere in my arteries. I like to think of taking care of myself. I don't smoke. Blood pressure's great. Cholesterol's great. Sugars are great. I have no really risk factors for cardiovascular disease. But would I be surprised if I have plaque in my circulation? Not in the slightest. Some element of plaque. So I'm asked to do these duplex scans to make sure the patient, or to diagnose a patient with peripheral vascular disease. Well, yeah, they got peripheral vascular disease because they have plaque buildup in their lower extremities, but it's not symptomatic. And so I've rationalized this in my mind that I will do the duplex scan, and I've been asked to do these tests, and I'll do them. And what I will always write in there is, yes, the patient has plaque buildup, has peripheral vascular disease, but they're not symptomatic. There's absolutely no role for any intervention on this patient. And so that establishes a baseline for management, which is there is no role for any kind of endovascular intervention in asymptomatic peripheral vascular disease. No symptoms. So going down that pathway, what's a symptomatic peripheral vascular disease of the lower extremities? Well, intermittent claudication. Intermittent claudication is very, very happens the same way every time, essentially. It is this, 3 parts to it. 1, I walk, whatever, half block, a block, 2 blocks, I get tightness in my calf muscle. I stop walking, number 2, I stop walking, it goes away. Number 3, I stop walking, I get the same thing again. I get about the same distance. So walk, I get tightness in my calf muscle, stop, it goes away, walk again, get the same thing. Now, if I walk faster, it's going to happen quicker. If I walk uphill, it's going to happen quicker. If I'm carrying something heavy, it's going to happen quicker. Why? Intermittent claudication, the tightness in your calf muscle you get when you start walking, is because when you're sitting there, you're okay. When you start walking, the muscle group that's furthest away from your heart in terms of motion wants more blood and you can't deliver it. Well, which muscle group is that? It's the calf muscle. So your calf muscle locks up when you start walking and stops when you stop walking because things catch up. So that's intermittent claudication. Walk a certain distance, I get tightness in my calf muscle. Stop walking, it goes away. Start again, comes back again. If I walk fast or walk uphill, it happens quicker. If I'm carrying something heavy, it happens quicker. Now, if you keep walking, it can go up depending on the location of the blockage into your thigh muscles and your buttocks. And if it's upstream higher, the blockage is upstream higher, then you can have other symptoms from it. In males, erectile dysfunction, buttock claudication. When you walk, your butt really tightens up on you. So that's intermittent claudication. The risk factors again: high blood pressure, high blood sugar, cholesterol, family history, circulation problem, age, and cigarette smoking. Okay, some people will have these symptoms and they're mild and they don't really limit your physical activity. Some people will have pretty significant symptoms. Okay, so how do you manage this? Well, you always want to try and be conservative initially, at least. Okay, what is conservative management? Well, the keys are risk factor modification. Blood pressure, cholesterol, blood sugar have to be controlled. I think the really key is that cigarettes smoking cessation. So how do I approach that in people? My dad smoked for 60 years. The day he quit was the day he decided to quit. I don't think if you don't have that in your mind that you're going to quit, you're not going to quit. So it's the mental control of things. And that's part of it, is the breaking the old habits. I sit down with a cup of coffee and I'll light a cigarette. You have to break those habits, but you have to mentally decide you're going to quit smoking cigarettes. Now, the other things like medication for it, acupuncture. My dad tried acupuncture. All those things are accessories, but the key is mentally making that decision to quit smoking cigarettes. But it does make a big difference to the natural history of this process. So what do I mean by that? Well, there was an old study called the Framingham study. Probably everybody groans when I bring this thing up. It's been a decades-old study. And if you look at the patients with peripheral vascular disease in the study, the ones who were not smoking had almost a 0% chance of losing a limb from their circulation problems. And the people who smoked had about a 10% chance over a 10-year period of time. So, that's one of the things we always worry about with peripheral vascular disease. Are you going to lose a limb? Now, most people do not lose limbs from this stuff. So peripheral vascular disease, symptomatic management, risk factor modification, try to get off the cigarettes, blood pressure, cholesterol, blood sugar control, exercising program. Remember, when you get that tightness in your calf muscle when you're walking, there's no damage being done to the muscles. They're just kind of complaining about it. Hey, I'm not getting blood down here. So the exercising program, what it does is your body says, hey, this muscle group's not getting enough blood. Let's get alternative channels to get more blood down there. So you have to really stick to the program, and it won't go away in the next week or two. It takes about 2-3 months to get better with time. But you develop alternative channels to get more blood down there because of the calf tightness. Again, there's no damage being done to the muscles, so exercising program is really important. There's supervised exercising. There's, you can do it by yourself. Supervised exercising is where you go to a therapist and they put you through a program of exercising. So supervised exercising programs work. Medicare actually covers, I think, up to 36 sessions. So it does work, but you have to take time out of your day to go to a therapist. And there's not a whole bunch of these supervised exercising programs, but it is covered by Medicare. Or you can do it at home. My patient population, they have a tough time getting to these facilities. So I set them an exercising program. What I tell them is, look, if you can walk a block before you get really bad tightness in your calf muscle, walk a block, come back the next day I'll walk a block in 1 step. Next day, walk a block in 2 steps. And slowly increase your activity level like that, so that over time you develop alternative blood channels that bring more blood flow down there. But if you don't quit smoking cigarettes, the chances of you improving is low. So if people are able to, control their blood pressure, cholesterol, blood sugar, get off cigarettes and start an exercising program, they have about a 60% chance of just improving by themselves over a 3-month period of time. It's pretty good odds. So that's conservative management. Now, there's medications you can try. The old medication that we used to prescribe when I was at the VA in Minneapolis is Trentol. We don't prescribe that much anymore. It really doesn't, I don't think it helps very much. There's something called Platol, which is generic, 100 milligrams twice a day. I usually start people at 100 milligrams a day and at nighttime, and then I'll tell you why, and then increase the dosage to 100 milligrams twice a day if they tolerate it. That's the key. How do they tolerate it? What's its efficacy? So the side effects of the medication are abdominal pain, diarrhea, headaches, nausea, increases your heart rate slightly. It's got a black box warning about people with congestive heart failure can't take it. Not that many people are in active congestive heart failure. Its efficacy, how well it works in terms of like making you walk better, I'm not enthralled with it. I'll be perfectly honest with you. It maybe helps about 30 to 40% of people walk for the distances, but the side effects, 20% of people have side effects from it. So I'm not sure the great benefit for it, but I do offer it to patients if you want to try the Platol, try it. I don't think it's any harm done, but if you get side effects, stop it. The reason I start them at 100 milligrams at nighttime is because of the headaches. So people, when they take it, the 100 milligrams at nighttime, they tend not to, in my opinion, tend to not get as many headaches. If they tolerate that, fine, go to 100 milligrams twice a day. Try it for a good month or so. If it doesn't work, stop it. It's not going to help you. Again, Trentol, I don't think really has any efficacy in terms of intermittent claudication. So exercising program, to summarize, conservative management, exercising program, blood pressure, cholesterol, blood sugar control, smoking cessation is the key. Why do we worry about peripheral vascular disease? Well, peripheral vascular disease is, again, one of the reasons people lose limbs, and I'll spend a separate video talking about that, because that falls in the category of critical limb ischemia, which is a different thing. So with intermittent claudication, conservative management, if that doesn't work, more aggressive approaches. Most people don't need aggressive approaches, especially if they don't really have anything that limits that lifestyle. And that's the key. That's the key. Just because you're symptomatic doesn't mean you need fixing. So if you come to my office and you tell me, look, yeah, I can walk a block or two. I'm 80 years old or 75 years old, and my lifestyle is not particularly altered by it. I'm able to do things I need to do. The quality of my life is fine. It's not really limiting my physical activity. My activity is normal daily living. Don't fix it. Do not fix it. Why? If you head down this pathway of fixing stuff, then, especially if you're still smoking, you're going to come back for more and more of it. People may disagree with me on that one, but I've been doing this for a long time. I can just tell you. If your symptoms do not limit your physical activity level, do not affect the quality of your life, you're happy with it, do not let people convince you to have interventions done. Be conservative. Blood pressure, cholesterol, blood sugar control, stop smoking, exercise regularly. That's the key. The chance of you progressing, especially if you're not smoking, to loss of limb is almost zero. You go through an intervention, your risk for loss of limb, especially if you're asymptomatic, is higher, because you go down that pathway of intervention and more intervention, more intervention. Okay? Why do we worry about peripheral vascular disease? Well, really, what we should be worrying about as physicians with intermittent claudication is, if you look at say if somebody comes to my office and we diagnose them with intermittent claudication, okay, they have intermittent claudication, conservative management, great, fantastic. What's the deal with that? Well, there's three sites that you typically get peripheral vascular disease. And I always tell patients this. So I always listen to the neck arteries to look for the cervical bruit. Sound of abnormal blood flow in the neck arteries doesn't always mean it's narrowed. I mean, especially women, that's tortuous arteries. So sometimes you'll hear these bruits in women's necks. Doesn't mean quite as much, but listen to the neck arteries. If there's an abnormal bruit or cervical bruit sound, vibration sound, we can often detect it with a stethoscope, and then perhaps head them down towards a carotid duplex to make sure they don't have significant hardening in the neck arteries. Why? Because significant hardening in the neck arteries predisposes you to strokes. Now, again, I'll kind of get into that. I think carotid artery surgery is done way too much too, but strokes from carotid arteries. But the real thing is, every time I see patients, I ask them, and my patients will tell you, I'm like repetitive. I'm like a broken record. Are you having any chest pain or shortness of breath with exertion? Often people have, a long history of smoking, so they have COPD, they have shortness of breath. Has your nature of your shortness of breath worsened? Has it changed in any way? Women, chest pain is, women don't get all the typical signs and symptoms of heart disease. That's what I'm worried about. So, women's, just sometimes you have to be really careful. Jaw pain, down the arm, all these type of symptoms of heart disease. So what's the deal with this stuff? Why the heart disease? Because somebody comes into the office and they have intermittent claudication. Their 5-year risk for having a heart attack or dying from heart disease is about 30 to 35%. And so in my mind, that's the key to all this risk factor modification. You having chest pain, shortness of breath, stroke symptoms? Again, we're into strokes later on. If you're having chest pain, shortness of breath, you need to see your PCP, you need to see your cardiologist, especially if you're getting worsening shortness of breath and chest pain, because their 5-year mortality is 30 to 35%. So to kind of summarize, peripheral vascular disease, asymptomatic, absolutely no treatment necessary in terms of endovascular or surgical. Do not let anybody do anything to you. Intermittent claudication, tightness in my calf muscle when I walk, a block or two, or even a half a mile. Stops when I stop walking, comes back when I walk again. Very, very regular, it always happens that way. If I walk fast, it happens quicker. If I walk uphill, it happens quicker. Intermittent claudication, risk factor modification, blood pressure, cholesterol, blood sugar control, stop smoking cigarettes, the key. The natural history of intermittent claudication is very benign. It tends to not progress unless you're smoking or if you have risk factors that are out of control. And then past that point, what's called critical limb ischemia. And that's managed more aggressively. The vast majority of patients with peripheral vascular disease are asymptomatic or have intermittent claudication that's mild or not lifestyle limiting, and they do not need surgical intervention. They do not need fixing. Again, the story, as I said in one of my previous videos, a patient I'd been following for intermittent claudication, lovely lady, 70-something years old, minimal symptoms, normal activities of daily living, quality of her life was excellent, not having signs and symptoms of critical limb ischemia, which I'll talk about. Cardiologist tried to convince her that she needed intervention. Absolutely not. Absolutely not. That goes against all societal guidelines for management of peripheral vascular disease. Again, I'm not picking on cardiologists, vascular surgeons, interventional radiologists. I can, tell you we don't always follow these guidelines. In fact, I just saw an article on that in Society of Vascular Surgery with aneurysm repair. It's hard to get this information if you're a lay person. So just you're your best advocate for this stuff. These vascular centers that screen people, I mean, you've heard about it in the news. and I think it was in Arizona, people getting screened, having interventions. It was a case of a lady lost her lower extremity. Be very wary of these vascular centers. Again, I'm not trying to badmouth, everybody or people. I just think you need to know that you really don't need intervention for most of these conditions. And so before you head down that pathway, really get informed about this stuff.